So here we are. This is my talk. So if you look at the anatomical features of zone 6, we are aware that we have juncture tendinum, which connects to the extensor ditorum communis. Then we have extensor ditorum communis from index to the fifth finger, and we have extensor indicis proprius on the index and extensor dt minimi on the small. And then proximally, we have synovial lining, and proximal to that, we have an extensor retinaculum. So from the wrist joint onwards to the metacarpophalangeal joint, that is termed as zone 6. Very interestingly, you will see that zone 6 is relatively a larger area. And distally, you may see that the juncture tendinum may be absent between the index finger and long finger. And at times, you may see multiple slips of extensor ditorum communis tendon. And then at times, you may have an injury to the extensor carpi radialis longus, extensor carpi radialis brevis, and extensor carpi ulnaris. So you can very well see that number of structures may be traumatized depending on the level of lesion. So here, of course, we can see that if you have an injury distal to juncture tendinum, the tendons have no retraction or just a minimal retraction proximally because they are held together by juncture tendinum. But if you have an absent juncture tendinum between index and long, obviously there is no supporting action provided by juncture tendon, so therefore the tendon is index tendon. If it is transected, it is likely to retract proximally and significantly. And then proximal to the juncture tendinum, if the tendons are transected, they definitely will have a retraction tendency. And this retraction or the amount of retraction will be dependent on the active tendon load at the time the tendons are transected. You may see either a single or multiple extensor ditorum communis tendon transection. Your extensor indicis proprius and extensor dt minimi laceration or EIP and EDM may accompany the extensor ditorum communis depending on how the tendons and where the tendons are transected. So interestingly, isolated EDM lacerations are relatively rare. However, they still happen, and therefore they need a specific consideration. So looking at the tendon transection distal to extensor retinaculum, of course, we know that the synovial lining will be invaded. There are a number of articles where they have quoted that intrasynovial tendons have lesser tendency to form adhesion formation. Is it really true? I don't think so, because I've seen extratendinous tendon repairs forming maybe not similar, but similar amount of adhesion formation, restricting tendon excursion distally as well as proximally. And I've seen if the injuries are in the proximity of extensor retinaculum, gliding of these tendons becomes challenging, and therefore patients often lose significant amount of amplitude of tendon motion proximally as well as distally, giving you complete disturbance or greater disturbance of the tendinous transection. So the question then arises, could zone 6 be divided into 3 different categories? One, distal zone 6, central zone 6, or proximal zone 6. And the reason I'm pointing it out here, the proximal zone 6, is especially because the tendons emerge out of extensor retinaculum and they are closely situated with each other. However, they tend to diverge at a specific angle from wrist and onwards. So should these 3 levels of injuries be treated differently, or should we say that all the levels of these injuries can be successfully treated by means of ICAM or relative motion splinting? So I leave that question to you, because in my opinion, these 3 levels of injuries must be treated differently. Traditionally, if you look at the literature, you will see a whole slew of extensor tendon management. So traditionally, patients have been fitted with a volar splint, extending up to 4 weeks and sometimes longer, depending on the type of repair these patients have had. And there are various protocols that have been uh, published in the literature. Some literature say that wrist and MCP joint should be kept in extension, and the amount of extension is dependent on which surgeon wrote that particular article. So we'll see that there are variations in terms of positioning of the wrist joint and positioning of the metacarpophalangeal joint, as well as interphalangeal joints. Some authors believe that MCP joint should be held in full extension, whereas or slight flexion, and some authors prefer that IP joint should be kept in full extension and free to move at times, depending on the level of injury. So I've seen variations of these management in my clinical practice, and I always wonder which method of these management is suitable for what levels of these injuries. So patients who are given a splint that maintain wrist in extension and metacarpophalangeal joints in extension, I've seen that these patients had a high tendency to form PIP joint flexion contraction. So in my opinion, this is the PIP joint flexion contracture must be prevented by positioning the PIP joints in neutral or in extension by an additional splint that minimizes uh, position of the PIP joint in flexed posture. But looking at the complications associated with immobilization, I've seen that patients have often gone into forming tendon adhesions. So this is a patient who had extensor deuterum communis repair at the metacarpophalangeal joint, and obviously on examination, when the splint was discontinued, on examination it appeared that patient ended up having extensor quadriga. So extensor quadriga, I've seen that it went into forming secondary swan neck deformity. Now one may wonder as to why that happens, because we can see that lack of extension or lack of full extension at the metacarpophalangeal joint will ultimately produce an adaptive change at the intraosseous muscle, and patients will develop intraosseous tightness over time, going into swan neck deformity formation. The other complication associated with immobilization is extensor contracture, which enables patient to perform complete composite flexion. And composite flexion is flexion of the MCP, PIP, and DIP joint. So depending on which finger is involved, patient may have flexor quadriga. One of my studies we did to find out which finger is the most problematic finger for producing flexor quadriga, we identified that the ring finger was the most notorious one, and then the second most notorious one with the long finger, and then the small finger. So you are either going to have extensor quadriga if you have an extensor lag at the metacarpophalangeal joint, or if the person is unable to flex the metacarpophalangeal joints as well as interphalangeal joint, the likelihood of having flexor quadriga. So zone 6 and zone 8 management is somewhat similar to zone 5 and zone 6, which has been reported in terms of positioning the fingers and wrist in extension. So this is a patient who had extensor tendon repair of long, ring, and small. Patient was fitted with a resting hand splint, leaving the fingers free. So patient kept on moving PIP and DIP joints. However, we had to prevent the flexion contracture at the PIP and DIP joint. Or at times, you'll see that patients may be fitted with the full resting pan splint. So all these splints are notorious in a way that it will produce limitation or severe limitation in flexion of the wrist or flexion of the fingers. So these type of injuries definitely result into serious contracture formation, especially if the wrist and fingers are immobilized. So patients show extensor tendon tightness, and then they have loss of composite flexion or extension of the fingers with loss of motion of the wrist or associated motion of the wrist as well. So current trend in zone 6 management is changing. Patients are now being managed by ICAM Splint following an extensor injury of zone 5 to zone 8. So since, excuse me, since the anatomy of zone 6 changes, then the question arises whether ICAM splint management for every level of this injury is ideal. So I think we further need to do some more additional research to see how the results fare with the management of ICAM for all the levels of this injury. So this is Dr. Merritt performing repair of the extensor tendon at the metacarpophalangeal joint, as you see right here. Patient is fitted with ICAM or relative motion splinting in order to mobilize the MCP and IIP joint. But the trend now is changing. Patients are often left with ICAM splint alone and not allowing these patients to have any wrist splint. So this is again raises a concern, because if you are not providing a support to the wrist joint and allowing patient to use the fingers with ICAM alone, then their likelihood of having tendon ruptures. So we identified that here we repaired the tendon proximal to juncture tendon, as you can see right there. The wrist is held in extended position. We flexed the metacarpophalangeal joint as well as interphalangeal joint. As you can see, the tendons are gliding well. There is no stress placed at the repair side. And then the specimen did not show any disturbance at the repair side. But when we allowed motion of the wrist and the fingers, we identified significant stress placed at the repair site, and we identified that there was a failure of the sutures that was used to repair at this level. So that brings us back to look at Minamikawa's work, who identified that to reduce the tension on the repair side, the wrist must be positioned in greater than 20 degrees of extension. So that holds truth actually if you allow the person to perform composite motion of the wrist and fingers, even though they may be using an ICAM splint. Gradually over time, there'll be a failure of the repair, and ultimately patients will end up having rupture of the repaired tendons. So we identified in our cadaver lab that as the wrist was brought in flexion, the stresses at the repaired site increased significantly, and finally with wrist flexion and flexion of the fingers caused failure of the tendon repair. So therefore I'll caution you that please consider providing the wrist splint and allow the motion of the MCP and IIP joint with ICAM splinting. So my personal preference, again, I'm repeating this, to position the wrist in 30 degrees of flexion, and with the Yoke splint allow digital mobility in order to prevent excessive stresses placed at the repair site that is caused by composite motion of the wrist and fingers. So this is an ICAM splint, and you may often have heard Dr. Lalonde speaking about the pencil test. So he normally places the pencil between the fingers and identifies how safe it is to move the fingers. So here the patient has a long finger extensor tendon just at the metacarpophalangeal joint. Especially this should be considered as zone 5. However, zone 6, closer to the juncture tendon or distal to juncture tendon, I think they are much more safer to use ICAM when you're using this one. So involved finger is kept in slight hyperextension as compared to the adjacent digits. That is the principle, provided they have presence of juncture tendon in order to provide external or adjacent support from juncture tendon. And then you begin with active range of motion of MCP and IIP joint. The splint is used for a period of about 6 weeks. My recommendation is not to attempt any strengthening for at least good 10 to 12 weeks. And these are based on tendon studies. And it's important that we monitor and prevent PIP joint flexion contractures at every situation. So this is a patient who has a small finger extensor tendon repair, uh, both actually extensor digitorum communis and extensor digiti minimi, both were cut. Patient was fitted with an ICAM, and you can see that the splint requires revision so that the patient has an adequate amount of motion of the PIP and DIP joint. So this needs to be trimmed. So the principle is to use uh, an ICAM splint or a Yoke splint. It is called also is called as a relative motion splinting. So the principle is to keep the involved finger, involved MCP joint in hyperextended position as compared to the adjacent metacarpophalangeal joints in order to relieve the tension at the repair site. The results with this is excellent, and I would strongly recommend that this is an ideal management for zone 6 distal. But if it is zone 5 zone 6 distal, if it is zone 5 proximal, and there are multiple tendons involved, then the management should be different. But very interestingly, you would see that extensor indicis proprius and EDC are at times repaired as one tendon. And in my opinion, we should avoid repairing both these tendons together. They need to be repaired separately. So here on cadaver dissection, I'm pulling on the extensor indicis proprius and extensor digitorum communis. And you can see that the patient has maximum motion of the metacarpophalangeal joint as well as interphalangeal joint. But despite of separate repair of extensor indicis proprius and extensor digitorum communis, you may see that patients may end up having adhesion formation between both these two tendons. And especially when that happens, patients are not very happy because they are unable to completely extend their fingers, extend their index finger while their adjacent fingers are in flexed position. So this is one of my patients who was dissatisfied with his results because he couldn't extend his index finger independently when the adjacent fingers were flexed. So we went back to our biomechanics lab, we sutured the tendon, and we identified that because both these tendons were stuck together, upon pulling on extensor indicis proprius, the extension of the MP joint was incomplete, as you can see right here, and we could simulate exactly the same situation as the patient demonstrated clinically. So here, of course, EDC and EIP combined, it extends all the three joints, whereas here he is unable to perform independent extension of index finger alone due to EDC and EIP getting scarred together. So how do we manage that? You may see this type of situations arising quite frequently. In this situation, you may consider fitting these patients with reverse Kleinert or an ICAM splint for a period of about 6 weeks, depending on the tension at the repair site. If the reverse Kleinert is recommended for the management of these repair, then it is essential for us to identify how much is the safe arc of motion permissible at the metacarpophalangeal joint as well as interphalangeal joint. And secondly, if the resting or static splint is recommended, it is always essential for us to understand the safe positioning of the wrist and MCP joint in a static splint. We begin with active motion of all the digits, especially upon completion of either immobilization or completion of 4 to 6 weeks duration of reverse Kleinert or Yoke splint. Then in order to physically allow EIP and EDC to move separately from each other, my recommendation is to strap the long ring and small finger in flexion with co-band wrap and encourage patients to perform independent extension of the index finger. And then after about 8 weeks period of their initial management and the management here as I've shown, we can begin with resisted extension of the index finger while the adjacent digits are held in flexion, and then we can perform resisted extension at about 8 weeks following their initial management. So this is a patient with the modification of this treatment. Here he has both these tendons repaired, just proximal to the MCP joint, and here is clearly demonstrating his ability to independently extend his index finger and has no restriction in terms of motion. If patients have multiple tendons involved in zone 6, they are not the suitable candidate for ICAM management. So the recommendation is that they are fitted with the dynamic extension splint. This patient is somewhat different. He also had some carpal injuries as well, and therefore he needed wrist stabilization. However, with wrist casting, we encourage the patient to perform motion of the metacarpophalangeal joint as well as interphalangeal joint because he had multiple tendons repaired at distal zone 6 region. So we term this as a reverse Kleinert technique because the whole management is based on Kleinert principle. When you perform resisted flexion, especially when the extensors are repaired, the extensors synergistically relax. So this is relating to the extensor tendon management, whereas true Kleinert principle meant that when you perform resisted extension, your flexors, those which are repaired, they synergistically relax, and therefore allowing this amount of motion with controlled mobilization in Kleinert technique, they allow the tendons to glide, preventing firm adhesion formation between the tendons as well as the fibrosing sheath. So the concept was first introduced by Evans and Burkhalter, and then there were a few other studies such as Thomas, Newport, Shukla, and other research demonstrated that early control mobilization with dynamic splinting is beneficial. However, we need to make sure that we initiate 30 degrees of motion at the metacarpophalangeal joint in first week and then increasing 15 degrees arc of motion on a weekly basis. So this is based on Dr. Paul Brand's principle of biomechanical reasoning. Dr. Brand introduced the concept that tendon travels 1.5 times the radius when the joint is moved to 90 degrees. So he calculated the amount of amplitude of tendon motion. So he calculated the radian angle, the 1 radian angle when you bisect the angle, on the circumference equal to 1 radian distance, then 1 radian angle is 57.29 degrees. In other words, if you round this off, 1 radian angle is equal to 60 degrees. So you can imagine in order for you to move the joint to 60 degrees, the tendon travels 1 time the radius. And then if you add another half time the radius, the joint therefore moves to about 90 degrees arc of motion. So Evans calculated that if the moment arm distance is 10 millimeters, then about 28.64, or in other words, if you round this off, the 30 degrees motion will produce 5 millimeters of tendon expression. So her analogy was such that she was trying to compare the amplitude of motion at the joint based on Durand's principle. We know that Durand mentioned in his article that 3 to 5 millimeters of tendon motion is adequate in preventing firm adhesion formation between the tendons, especially in a fibrous sheath. So Evans used this calculation, which was originally based on Dr. Brand's principle of radian angle, and based on that, the controlled mobilization program was introduced by using dynamic splinting. So moving the MCP joint to 30 degrees produced 5 millimeters of tendon motion if the moment arm distance was about 10 millimeters. So we have treated a number of these patients who have had multiple tendon transection or repairs. We initiated with 30 degrees of flexion in first week with 15-degree increment on a weekly basis. At 6 weeks, the dynamic splinting was discontinued. Patients were then placed on early controlled mobilization program and then gradually increasing their arc of motion gave them relatively greater results. So the reverse Kleinert splint was used somewhere between 4 to 6 weeks, depending on the type of sutures these patients have or type of injuries these patients have. So here is the patient who had a multiple tendon repairs. I hope this works. Multiple tendons repaired, and the patient had complete motion of the fingers. He had 3-finger especially involved. So a thumb extensor tendon, it is important for us to consider the level of injury as well. The thumb injuries are thumb extensor tendon are divided into zone 1, zone 2, zone 3, 4, and 5. So if the tendon transection is distal to the metacarpophalangeal joint, there is no or relatively minimal tendon retraction proximally. So zone 1 and 2 can successfully be treated by means of a static thumb splint, and they can begin with short arc of early motion. So active motion to 30 degrees is permissible, and this is called as the short arc motion program that was introduced by Evans in late 90s, and this gives relatively an excellent result. But if the tendon transection is proximal to the metacarpophalangeal joint, then the tendon retraction is significant. So in such situations, it is essential for us to look at the status of the tendon repair. If the patient has relatively stronger repair, we can begin with short arc of motion program. Patient may be given a dynamic splinting, and the controlled active mobilization can be instituted, especially depending on the level of repair. If you look at if you compare the EPL and EPB function, we can very well see on a dissected thumb that EPB is only an extensor of the CMC joint. Even though the EPB inserts distal to the MP joint, it has no action whatsoever distal to the MCP joint. So here I am pulling on EPB. I can see that CMC joint is extending, whereas nothing happens at the MCP joint. So let's look at this video again. So pulling on EPB alone doesn't extend the MP joint. So therefore, by pulling on EPL, EPL is a complete extender of the IP joint of the thumb, MP joint of the thumb, as well as the CMC joint. So here this is a video taken from a different angle. EPB doesn't perform any active extension of the MP joint unless you start activating the EPL as well. So EPL technically is an extender of the MP and IP, including the CMC joint, whereas your extensor pollicis brevis only extends the CMC joint of the thumb. So therefore, we must consider the gliding amplitude of the first extensor compartment and third extensor compartment as well. So we looked at the complications in the vicinity of extensor retinaculum. We identified that the injuries in the vicinity of extensor retinaculum definitely produces massive or severe limitation. So this is a patient who had a repair of first extensor compartment tendons. The thumb and the wrist was immobilized in a particular degree of angle at the wrist joint, thumb CMC, MP, and IP joint. The tendons were immobilized for a period of 4 weeks in a cast, and then when the cast came off, patient had difficulty performing specific action such as opposition of the thumb to the small finger. And if we looked at the patient's arc of motion of the wrist, we identified that because the tendons were repaired proximal to extensor retinaculum, patient had greater radial deviation, as you can see right here. However, patient was unable to perform ulnar deviation of the wrist. So this suggested that it's important for us to look at the extensor tendon injury, whether it is proximal or at extensor retinaculum or distal to extensor retinaculum, and therefore we can manage these type of injuries somewhat differently. This patient was referred for therapy. We started with a mobilization program. However, when we were unable to regain her thumb opposition to index, long, ring, and small, she had utmost difficulty even opposing to the base of the fifth because the extensor tendon had significant gliding limitation beneath the extensor retinaculum. Patient, upon moving her wrist with the thumb, complained of severe wrist pain, and the symptoms were somewhat similar to decurvent tenosynovitis. However, it was not. We identified that extensor tendons, the first extensor compartment extensor tendons, had significant amount of gliding resistance when the patient performed radial motion. So we simulated this in a cadaver and identified that if the adhesions, if the tendons are repaired proximal to extensor retinaculum, patients will have significant limitation in terms of CMC, MP, and IP joint motion, and of course, patients will have difficulty performing ulnar deviation of the wrist and thumb opposition to index, long, or other digit. Or if the patient had tendon transection and tendon repair distal to extensor retinaculum, the patient will have difficulty performing radial deviation as well as thumb extension at the CMC, MP, and IP joint and thumb abduction. So simulating these clinical scenarios in a cadaver dissection definitely gave us an in-depth idea as to how these patients should be managed. So distally, if the patient had tendon adhesions, the tendons didn't glide through or beneath the extensor retinaculum. Extension of the CMC, MP, and IP was challenging, and then patient also had complaints of pain at this joint, especially when we looked at some clinical situations. So these simulations definitely helped in designing a treatment program differently. Here, of course, the patient had an EPL tendon repair proximal to extensor retinaculum, and the patient is demonstrating limitation of the tendon gliding, especially when thumb opposition was attempted. And here, of course, we identified if the EPL was cut down distal to extensor retinaculum, patient's ability to extend the MP and CMC, MP, and IP joint was difficult. The other complications were patient had loss of combined motion of the wrist and the thumb, that significant amount of joint compressive forces. This is from the experience that we had when the patient had limited motion of the radiocarpal as well as midcarpal joint. And because these patients had quite a bit of pain, we suspected that these patients will have a premature articular cartilage degeneration if they are not treated specifically in a particular manner. So we decided to manage these patients by using a controlled mobilization program using a wrist hinge splint. So here, of course, this is another patient where we allowed the person to perform isolated wrist motion towards ulnar deviation and radial deviation. We allowed the patient to perform isolated thumb, MP, and IP joint flexion so that the tendons glide proximally as well as distally. And of course, the tendons glide, especially the first extensor compartment glides in relation to the motion of the wrist joint as well. And then gradually over time, we increased the combined motion of the wrist and the thumb, MP, IP joint in order to maximize gliding of the extensor tendon respective of the wrist joint as well. So the management of abductor pollicis longus and EPB repairs, we used the wrist hinge splint for a period of about 6 weeks. We allowed patient to perform isolated wrist radial motion to 10 degrees in each direction with 10-degree increment on a weekly basis, and then isolated thumb flexion starting off with 10 to 15 degrees and then increasing by 10 degrees on a weekly basis. Now, there are a few reports that talk about dynamic splinting is an expensive management of these patients, and therefore this should be the dynamic splinting should not be considered because of the additional expense of the splinting. One would then challenge these authors by saying that would they consider patients having significant limitation in terms of wrist and thumb motion or combined motion of wrist and thumb, and have these patients go on to premature degeneration of the radiocarpal as well as midcarpal joint, whether they would be happier with the patient who are having CMC joint excessive loading because of limited motion of the thumb and CMC, MP, and IP joint. In my opinion, I think dynamic splinting definitely is not an expensive management because it definitely will give you a greater arc of results or greater arc of motion. So this is the patient who had an EPL repair, EPL tendon repair at the just distal to the extensor retinacular level. So he cut his tendon by an X-Acto knife while working on a plastic sheet. This is the level of lesion. However, the tendon retracted proximally right down to the proximal to the extensor retinaculum. The tendon had to be advanced for repair, and therefore this tendon repair was somewhat under tension. And traditionally, this repair could have been managed with a resting thumb splint. However, we decided that if we do not incorporate the wrist and thumb motion, we are likelihood of not having the gliding amplitude of the extensor pollicis longus tendon. So the consequences of immobilization was discussed with the referring surgeon, and then we fabricated a dynamic splint, allowing the wrist hinge to allow the wrist to move from certain degrees arc of motion from extension to flexion. So we performed isolated wrist motion, isolated thumb motion, and then after about 3 weeks, we incorporated the combined motion in the short arc of the wrist flexion and thumb opposition, wrist extension, thumb extension. By increasing amplitude of motion, we had excellent results. Patient had full thumb opposition to the base of the fifth. He had complete opposition to each and every finger, no pain and no restriction in terms of his tendon gliding. So complication of zone 6 proximal, we identified that patients, if they are treated by means of immobilization or reverse Kleinert splinting for finger motion only, we identified that if the tendons were repaired distal to extensor retinaculum, the combined motion of the wrist and fingers was maximally difficult. We identified that patient did not have any difficulty flexing the fingers but had some difficulty extending the wrist. And we identified that patient had no difficulty in flexing the wrist and fingers since the extensors were gliding distally. In zone 7 and zone 8, looking at the level of injury and level of repair, if the tendons were repaired proximal to extensor retinaculum, patient had no difficulty extending the wrist and extending the fingers. Patient had significant difficulty in flexing the wrist and fingers since extensors were gliding distally, and they had restriction traveling beneath the 2 layers of extensor retinaculum. Patient had some difficulty flexing the fingers and extending the wrist because tendons were had greater gliding resistance and the tendons passing through the extensor retinaculum. So the question then arises that is relative motion splinting or ICAM splinting and mobilization suitable for multiple tendon repairs in zone 6 to zone 8. So these are some of our cases where we were not very successful when we were using reverse Kleinert. These patients ended up having some tenolysis, and of course, following tenolysis, they had greater arc of motion. But could we possibly have avoided their tenolysis procedure if we had understood their pathology or pathomechanics better from the beginning? So here, of course, the patient had extensor tendon repair distal to extensor retinaculum. Here a patient is showing limitation in terms of extending the wrist and extending the fingers. This patient had tendon transection at the level of the wrist. At extensor retinacular level, you can see that he has a severe extensor lag of the ulnar three digits. He has difficulty extending the wrist and extending the fingers here as well. But in addition, if there are multiple tendons involved, then they end up losing independent motion of the fingers as well. So this is a patient who had extensor tendon repair proximal to extensor retinacle, and patient is here showing limitation in terms of wrist flexion and finger flexion. And of course, here the patient is demonstrating difficulty moving one finger at a time. So in addition to restricted motion of the wrist and fingers combined, patients also demonstrated limited finger motion as well. They could not perform independent extension of index, long, ring, and so on because these tendons had scarred down to each other in the proximity of extensor retinacle. So we looked at a particular case who was sent to us from a different hospital. This patient is 55-year-old male farmer. He had an extensor tendon repair 6 months ago at another center. Post-operatively, he was treated with a wrist mobilization for 4 weeks period of time. Wrist immobilization for 4 weeks period of time. He was then referred for hand therapy. He made some gains with therapy in terms of his finger range. However, the therapist could not gain much of the wrist motion. Patient complained of limited wrist motion associated with pain. He was from the hand clinic. He was referred to hand therapy for a static progressive wrist flexion splinting. So on examination in hand therapy, we identified that he was unable to move his wrist with fingers. His range of motion was limited in his wrist with fingers flexed as well as fingers extended. We identified that the wrist flexion was severely limited when the fingers were flexed. Patient complained of wrist pain when passive flexion of the wrist was attempted with fingers in flexed position. Patient reported that he identifies or he feels that something is grinding as he moved his wrist with an object in his hand. And in addition to that, he reported that whenever he worked with different types of tools on his farm, he kept on dropping his tools when he tried to use his hand, and he was kind of frustrated. So obviously, the static progressive splinting to regain his finger and wrist motion was not an ideal treatment of choice. So therefore, while we were in the clinic, we viewed his wrist motion fluoroscopically and suggested wrist tenolysis. So here he is looking at the complication that we identified fluoroscopically. Here, of course, he is moving his wrist in flexion and extension. His extension was good because the tendons were moving proximally. However, he could not flex his wrist completely. And on looking at his carpal and radiocarpal and midcarpal joint, we identified that upon flexion with fingers closed, there was compact appearance of radiocarpal and midcarpal joints, suggesting that he probably has significant amount of joint compressive forces as a result of tendon restriction and limited tendon motion distally. And this joint compressive forces were probably the cause of wrist pain in this situation. We looked at his normal wrist views and identified that he had no restriction in terms of extension and flexion, either with fingers in full extension or fingers with full flexion. However, with involved side, he had severe limitation as well. So this patient also had limited radial motion, as you can see. Fluoroscopically, we also looked at his radial motion and identified that his carpal kinematics was completely disturbed. He had severe limitation in terms of his range of motion. And one can imagine that if he is left with this much of motion, then all the ligamentous structures that provide the stability as well as mobility to the radiocarpal as well as midcarpal joint will ultimately, they'll become tight, they'll undergo an adaptive change, and subsequently they're going to have premature arthrosis of radiocarpal and midcarpal joint. So the patient, based on our recommendation, the patient went through the tenolysis procedure. Following tenolysis, the patient was fitted with the wrist CPM on a full-time basis. Then we mobilized after 4 weeks. We mobilized actively after about 2 days post-operatively. He performed wrist range of motion and forearm range of motion, 20 repetitions, 5 to 6 times per day, and he used CPM. Then remaining time, then we began with wrist and forearm and grip strengthening program at 6 weeks, increased it to 8 weeks, and at 8 weeks we initiated work hardening program, continued until 12 weeks, and then we discharged him at 12 weeks mark. So post-tenolysis, he has significantly greater range of motion in his wrist extension as well as flexion. With fingers flexed, he had full range of motion with finger extended, and on fluoroscopically, we identified that he has maximum range of his wrist in extension as well as flexion, and he had near normal range of motion of his radiocarpal as well as midcarpal joint fluoroscopically when we compared that with the contralateral normal side. So then the question arises, how could we treat these injuries following repairs? So this is a patient who had multiple tendon repairs just around the extensor retinaculum. His tendons were repaired just around the extensor retinaculum. I think okay. So here, of course, the patient is undergoing tendon repairs, and upon completion of tendon repairs at the extensor retinacular level, before the extensor retinaculum was sutured and the skin was closed, we looked at the safe arc of motion permissible at the level of the wrist as well as at the metacarpophalangeal joint. Based on that, we designed a program for this individual. We provided these patients with the dynamic splint. We call this as a double reverse Kleinert, which worked on a Kleinert principle. We allowed the person to perform isolated wrist flexion to certain limits, and then isolated flexion of the metacarpophalangeal joint to certain limits. So he was encouraged to perform 10 degrees of wrist flexion, and then we increased wrist flexion by 10 degrees on a weekly basis. We allowed the person to perform 30 degrees of metacarpophalangeal joint in first week with 15-degree increment on a weekly basis. And at 12 weeks post-operatively, the patient had full range of motion of the wrist and full range of motion of his fingers. He had complete independent motion of his index, long, ring, and small. I think the video is stalling, but here we can see he has full range of motion in his fingers. So this is zone 8, just proximal to extensor retinaculum, multiple tendons involved, and then we fabricated the dynamic double reverse Kleinert splint, allowing him to perform isolated flexion of the wrist, isolated flexion of the MCPs and IPs, and these are his results. And then similarly, we treated zone 9 repairs as well, where you have muscle belly repair as well. So there are various programs that discusses extensor tendon management a bit differently. Post-operatively, there's a Norwich regime introduced by Salides and the group. They provided these patients with the resting hand splint with wrist in about 30 degrees of extension, MCPs at about 30 to 45 degrees of flexion. Patients were fitted with the wedge splint to keep the fingers extended when not exercising. And their program consisted of short arc of motion of the wrist and fingers and gradual increase of motion at the level of the wrist and fingers. So this is another alternative method. However, my experience is I would rather spend time fabricating a splint and allowing the person to have a controlled motion of the wrist and controlled motion of the fingers for a certain length of time, and then go on to combined motion of the wrist and fingers, because we must understand that extensor tendons need to glide beneath the extensor retinaculum. If they do not have adequate gliding proximally or distally in relation to the fingers as well, then the serious uh, restriction may occur, not allowing the patients to perform combined motion of the fingers as well as the wrist. So there is another protocol written in the textbook, which is from Broomfield Hospital in UK. We'll look at, I compared a number of these post-op protocols to see whether these protocols or any of these protocols allow motion of the wrist and motion of the fingers, and then going into motion of the wrist and fingers combined. And I found that for lengthier periods of time, the wrist motion is not incorporated. So this protocol suggests that on day one after surgery, patient be fitted with the plaster of Paris, palmar splint applied after the tendon repairs. The wrist is kept in about 30 degrees of extension, MCPs in 40 degrees of flexion, and IP joints in neutral. And they began exercise program at day 6 when the patient performed 10 repetitions on an hourly basis. And then specific program consisted of allowing the MCP joint and IP joints to move, and then actively flex the MCP joint back to 40 degrees, and then fully flex the PIP and DIP joints to full flexion of the both over the end of the splint. And on 28 days, they introduced exercise of the wrist joint in flexion and extension with fingers relaxed in a form of a tenodesis manner. But if you look at stages of wound healing, there are a number of animal studies which have shown that contracture formation is profound in first 3 weeks following an injury or following a surgical procedure. So 28 days means we are way beyond the contracture formation period, and therefore if the patients are managed this late with motion of the wrist and motion of the fingers, we are likelihood of having limited gliding excursion of the tendon. There's another Manchester regime which mentions that in week 1, patient should be given a thermoplastic forearm-based splint with wrist in 21 degrees of extension, MCPs and IPs joints in full extension. Patient should be given a removable digital plate allowing IP joint flexion and extension exercises. And during week 1 and 2, IP joint flexion and extension exercises are performed about 10 repetitions on an hourly basis. Between week 3 and week 6, patient should remove the splint every 2 hours and commence gentle wrist motion with digits relaxed, and then commence on active MCP joint flexion and extension with wrist at 0 degrees or in neutral position. So these are the protocols, and you can see that every protocol talks about the timing somewhat differently, and therefore it leads us to believe that we must do comparative study in order to identify what is the final outcome with what type of a management. So therefore, randomized controlled trials are definitely essential when we are managing these type of injuries and looking at the specific outcome measure criteria. But very interestingly, upon doing a literature search, I came across an article that was published back in 1969 in the journal called Journal of Gynecology and Obstetrics. I was kind of surprised as to why this hand paper, appeared in Journal of Gynecology and Obstetrics. But interestingly, upon doing further investigations, I identified that that was the only journal back then which accepted different types of publications, whether it be related to hand, related to shoulder, related to wrist, and so on. So Dargan introduced an outcome measure criteria. He pointed it out in his article that if patients have no extensor lag and patients have an ability to flex the fingers to the pulp to mid palm, they fall into an excellent category of recovery. His good category included extensor lag less than 15 degrees and patients yet having ability to flex their fingers pulp to mid palm. The FAIR rated that if the patient had extensor lag between 16 to 45 degrees and pulp to palm distance was 2 centimeters. And poor was if the extensor lag was much greater than 45 degrees, pulp to palm distance is greater than 2 centimeters. However, looking at these criteria and applying that criteria to the injuries in the vicinity of extensor retinaculum or injuries from mid zone 6 and to zone 8, this criteria is totally not suitable to look at the outcome measures of these patients who have had tendon repairs. So what I'm proposing is that excellent is no extensor lag, full finger flexion and extension with wrist in full extension as well as full flexion. And then criteria, patients showing extensor lag less than 15 degrees, yet having full finger flexion and extension with wrist in full flexion as well as extension, that should fall into a good criteria. And FAIR should be if the patient had an extensor lag of 30 degrees with 50% finger flexion and extension with wrist in 50% of flexion and extension, comparing with the contralateral side. And poor will be extensor lag greater than 45 degrees with greater limitation of combined wrist and finger flexion as well as extension. So I have about 15 to 17 cases who were in the vicinity of extensor retinaculum, and I would like to write up on these patients and use these proposed protocol or criteria to see how my patients have fared with the management that I have described. So in conclusion, extensor tendon injuries are considered trivial, but they are not. Extensor tendon anatomy, we know, is very complex. It's not only extensor deterrum communis or extensor indicis proprius or extensor DT minimi that makes extensor anatomy, but extensor anatomy distal to the metacarpophalangeal joint is definitely received the contribution from intrinsic musculature and therefore intricate relationship between extensor deterrum communis, or in other words, the extrinsic extensors and intrinsic extensors should match and interplay with each other complexly in order for the person to have full flexion and full extension, irrespective of motion of the wrist. The biomechanics of the extensor tendon or extensor mechanism is much more complex than flexors, and extensor tendon mechanics reconstruction is difficult, if not impossible. So therefore, management, we cannot generalize and say that one particular management fits all, because it doesn't, because excursion of the tendons differ, the interference of different structures is definitely different in different regions. So therefore, the extensor tendon management must be specific to the location of injury, type of injury and type of surgery these patients have had. And of course, we must incorporate our treatment program in accordance with the type of injury, type of surgery, and level of injury while treating these patients post-operatively. Thank you very much.